Welcome, everyone. I am Mariset Hassan with the South Carolina Coalition for the Care for the Seriously Ill, which we affectionately call CSI. We have been in existence as a coalition here in the state since 2010. We were started formally under the umbrella of the South Carolina Medical Association as a work group of their bioethics medical committee. And so since then, we are now currently under the umbrellas of Health Sciences, Health Innovation Group, which is the backbone and host for both of our serious illness coalition in North Carolina and in South Carolina. What we absolutely love doing is convening and doing education. And as you know, we have just recently been doing some work around post, and we're very instrumental in doing a post pilot as well as getting post legislation passed in 2019. During the COVID years, we began to do an annual symposium. And of course, it's hard to believe that it's 2025 and COVID ended right in 2023, just a couple years ago. So we welcome you guys to be here this week. Our theme is From the Heart Failure Care Continuum. And so every day, today, Tuesday, Wednesday, and Thursday, we'll be doing a little bit of a deeper dive into looking at the serious illness of heart failure and what we do in terms of how we provide care. What are some clinical things that can be considered, as well as looking at a very new palliative care model in our state. On Thursday, we'll wrap up hearing from Caranova and the work that's being done with them as well. So glad to have each of you. If you're just joining us, we encourage you to introduce yourself, put your name in the chat, the name of your organization, and I'm going to go ahead and introduce our guest speakers for today. We have Michael Jawiski and Crystal Gordon, who are both with us from Prisma Health in terms of their Advanced Heart Health Center. Mr. Jawiski is an advanced practice nurse specializing in heart failure, research, cardiogenic shock, and advanced treatment modalities. He graduated from the University of South Carolina with a master's in nursing, with a concentration in adult gerontological acute care nursing as a nurse practitioner specialty in 2018. He's board certified, and he has some subspecialty areas as well. In the areas of amyloidosis, hypertrophic obstructive cardiomyopathy, and other things as well. Crystal is a licensed master social worker who serves as the heart failure and LVAD social worker at the Prisma Health Advanced Heart Health Center. She also has some experience as a home social worker, dear to my heart. I did a little bit of home health and a lot of hospice, and spent 20 years in the field of substance use prevention. So she has done a lot of work across state, county, and federal and international settings, and has been coordinating and managed multi-year grants. This is huge right here, of $10 million. So she received her bachelor's degree in social work from Winthrop and her master's in social work from the University of South Carolina, both institutions that we know and love well here in South Carolina. So Crystal and Michael, I'm going to give it to you. We'll have time for questions at the end. We also will provide you with the slides and the recording of this presentation after we conclude. So once again, Michael and Crystal, thank you for being with us today, and take it away.
Great. Thank you for that. So everyone, my name is Michael Gajewski. I'm a MP with the Advanced Heart Health Center. We're part of Prisma Health, specifically in the Midlands area, kind of under the Heart and Vascular Institute umbrella. And we see a lot of heart failure. And so I'm glad to be talking about it this year, especially with the grant coming out of the AHA dealing with palliation and heart failure, because it is a very prevalent disease in our area, and it does have a lot of disease burden on our communities. So I want to share a little bit about what heart failure is and how we treat it and how those treatments help alleviate some of that burden. So let me see if I can figure out how to work a slide here. Okay. So our objectives will be to identify at least 2 heart failure therapies. Sorry, my screen's here in the way. Nope, that's not what I want to do. Chris, can you help me with technical stuff? Is sharing? Can y'all see the slides on your end? Because they've disappeared from ours.
Yes, we can see the slides. Mhm.
So we're going to bring it back up on our end. Give us 1 second.
Okay.
Maybe.
Please. Okay, we're going to stop sharing for a minute.
We can see the 4 identify, describe, define, and list very clearly under the objectives.
There we go.
Oh, there you go. Okay, great. There we go. Is it working? Sorry, we're not used to Zoom. We're more of a Teams-based
We're in a guest
institution.
space right now.
Yeah, exactly.
Okay, cursors are working now.
Okay, so I can't see y'all anymore, but I can see the slide. So define at least 2 patient barriers to advanced directive completion and list at least 2 ways to incorporate advanced directives into your practice. So agenda, we're going to go over some heart failure, how we treat heart failure, and also how we deal with advanced directives, morbidity, mortality, benefits, and barriers, and inclusion of these guidelines into your practice. So what is heart failure? So heart failure in a nutshell is your heart cannot meet the circulation requirements of your body, either due to failure to squeeze, failure to fill, or both. And 3, we categorize heart failure into 3 broad sense, which is preserved ejection fraction, heart failure, which is LVF of greater than 50%, moderate reduced, which is LVF of 40 to 50%, and then reduced, which is less than 40%. And what causes heart failure, very in broad strokes, is broken up into 2 etiologies: ischemic, which is anything that causes interruption of blood flow to the heart, such as a heart attack, and then non-ischemic, which is everything else. This encompasses everything from genetics to postpartum to medication-induced substance abuse. I'm sorry?
Yes, I did. Sorry.
Okay. Environmental factors. So everything else, thyroid conditions outside of ischemic cardiomyopathy. So what does heart failure look like? I think most of us can probably identify some heart failure from popular literature or movies. And it kind of looks like this guy on the left, right? These are people who typically carry a lot of water weight. They have swelling in their ankles, big neck veins. But everything you're seeing on the left side of the screen, this is end-stage heart failure. This is, this is when we're talking about hospice, not palliative care. On the right, you'll see a picture of former Vice President Dick Cheney. I don't know if anyone knows this, but Dick Cheney was a heart failure patient. He actually had an LVAD, a left ventricular assist device, and then eventually got a heart transplant at 71. So the whole time he was in office, he was dealing with heart failure and no one knows. And that's kind of what our typical patient in the community looks like. Kind of interesting fact about Dick Cheney is when he first got his device was kind of the advent of Bluetooth, and everyone realized quickly that we needed cybersecurity on our heart devices, because what if someone could use a cell phone to take over the vice president's pacemaker, right? So he was one of the, this was back in 2001, and then he got, transplant 24 months later. The classification of heart failure, there's 2 main classifications. You have the NYHA, which basically is based on symptomology of the patient. 1 being no symptoms and 4 being symptoms at rest. You can see the kind of the various shades of gray there. And then our structural classifications, which is A, B, C, and D. And if you read the text here, A is concern for heart failure, but no structural changes, no biomarkers. So these are people with prolonged exposure to high blood pressure, obesity, maybe a family history. And then when you get to stage B, C, and D is when you're actually seeing evidence of the disease. So our big task in our clinic is to keep people in the stage B, C, and then the stage 2, 3, because by the time they've got to us, of course, they've already been diagnosed with heart failure and are looking for advanced interventions. So just kind of keep those stages in mind as we talk, because those are kind of where our goal is to keep our patients. so that they're living meaningful lives. And then why heart failure matters to us. So the red on the graph here is heart failure. And if you look at South Carolina, there's a lot of heart failure. We're known as the heart attack state, the stroke state, but also heart failure state. If you look at where the red is in our state, it's a lot of the rural areas. So one of our biggest struggles is kind of community outreach. There's only 2 accredited heart failure centers in the state, and they kind of bifurcate the state right from Charleston through Columbia up into Greenville. And so if you're not, living in near one of those academic centers, there's not a lot of care going on in those areas. There's definitely not a lot of resources, even if someone's trying their best. So it's a big problem in our state. It's very prevalent in our state. It is a high mortality in our state. And it's difficult to combat, and we'll kind of go through some of these treatment modalities in a second. If you want to know how serious heart failure is, if you look at 2002, heart failure is mentioned in 14% of death certificates in the country, not our state. So it is one of the leading causes of death in the United States. Our mortality is higher than most cancers. If you are diagnosed with heart failure of any kind without treatment, we expect 60% of our patients to pass in 5 years. If you've been in the hospital twice in 1 year, we expect 90% of those patients to be passed at the 2-year mark. So it's a very burdensome disease and has a very high mortality and obviously a cost. You can see there $31 billion in 2021 or 2012. Sorry. And then there's the burden of this disease. So as we mentioned earlier, class 2-3 is where we're trying to keep our patients. 66% of these patients will have mobility problems. 68% of these patients report pain and discomfort. 3/4 of these patients will find just menial activities difficult. Your ADLs, this guy's walking his dog. And then 50% will be depressed, have anxiety. And then those surveyed, 65% of people said they would live shorter lives to have relief from their symptoms. So we're not only talking about the mortality here, but the burden of the disease. And we're going to share some of those modalities we have to fix that. So again, this is kind of what I was talking about, the mortality of the disease. So if you look on this graph, that first arrow with the first dip, that's usually where we meet our patients, right? So there's been some subclinical or clinical heart failure that's maybe been managed by primary care or general cardiologists out in the community. And then they finally get to an academic center or a hospitalization where they can be identified. And then, as we mentioned earlier, if you have 2 heart failure exacerbations in the same year, it's a 90% mortality. So this person only has 1 strike. So obviously we're trying to avoid the 3rd, 4th, and 5th hospitalization depicted there because they're going to be lined up for heart transplant. So what do we do to fix heart failure? Well, the staple of heart failure is medications. And we do this largely for the morbidity and mortality benefit, but as the focus of this talk is going to be on is palliative, there is a lot of benefit for these medications in that regard, as far as quality of life questionnaires and 6-minute walk times is generally how we assess these in objective data and literature. So medications here, GDMT, we'll go into these in detail here in a second, but basically there's 4 different medication classes that are essential to get patients on. IV iron, we're doing a lot of GLP-1s, which is like Ozempic or Mounjaro that you see the commercials for to help with weight loss. We have a robust remote monitoring program. Rehabilitation services, we do home cardiac rehab and outpatient, as well as pulmonary rehab. Home health services is a big utilized resource. We have home palliative care here at Prisma. And then device service, we'll go into detail, but these are quality of life improving devices. So here again, the 4 pillars of medications we use. Now, again, most of these medications, their benefit is prolonging life, but I do have some data here. Entresto is one of our most potent medications from the Paradigm study, which was in patients with reduced ejection fraction. We saw an improvement in Kansas City questionnaire score, which is the Kansas City questionnaire score. You're going to see that a good bit in these slides. Essentially, there's 7 domains, 25 questions. The score is scored in quartiles, 0 to 24, 25 to 50, et cetera. And when we ask patients about quality of life, we're looking at these scores to see if there's any meaningful improvement. And in Entresto, there was statistically significant improvement, but it was low. And actually with Entresto, because this was earlier on in kind of the development of heart failure therapies, it was better to have a negative change because the placebo change was worse, because we know heart failure gets worse over time. So the patients surveyed were well worse than on placebo. And then with Entresto, they're saying here was only 3 points worse than baseline. And this is over an 8-month period. And enalapril, which you see listed there, was the previous gold standard for heart failure medication. So an improvement over the previous standard, improvement over the placebo, but still not great, although better than what we had previously. So Entresto came out 2014. And then here you go, Paragon came out a few years later for heart failure with preserved ejection fraction. And again, we see our first increase by 1 point compared to placebo at 8 months, but still that is not great news for patients. We like to see them have better quality of life, although the medication does make people live longer, stay out of the hospital. Again, this is another class of medication we use. This would be like the prototypical drug for this would be spironolactone, which we see a lot. This is the mineralocorticoid receptor antagonist group. TopCat trial, large multi-center trial, showed a baseline of 55 points and demonstrated a 1.36 point improvement. So we're making steady progress at this point, but still these aren't huge shifts in quality of life. This is only going up by 1 point. Now, I will say that they have done other studies in combination of all these medications, which we're talking about, people did have a net benefit, but still we're splitting hairs here with quality of life. SGLT2s, the prototypical drugs for this you see are Farxiga and Jardiance. This information is pulled from the Jardiance studies. Again, you see the Kansas City questionnaire. This is more of a statistically important improvement. So we're seeing, 2 points at 3 months, 1.5, 1.5 at 8 and 12 months. So we're making steady progress, but and then this medication also keeps people out of the hospital and living longer. And the same is seen again here in HEF patients with an improvement about 1 to 1.5 points on their Kansas City questionnaire. And we do, we do see this endoli in clinical practice. People will come in saying they feel better, they can walk a little bit farther, they're having a little less swelling. So we see it clinically, but still not making great strides. So those are our 4 pillars of medication therapy that we try to get every patient on, regardless of what type of heart failure they have. And our goal is to get them on these medications in 8 weeks. So very aggressive, because we want to get them the most benefit symptomatically and also prolong their life. The best quality of life data we have for any medication is IV iron. We use IV iron a lot here in the clinic. Most heart failure patients will be iron deficient. It's between 50 and 80%. It has to do with the disease state. It's nothing nutritional. And we see with IV iron, now we're talking about 6-minute hall walk test, which is how far someone can walk in our hallway within 6 minutes. And we're seeing a 25-meter increase. So the gray here is placebo. So heart failure gets worse over time. So we're seeing a negative deflection there. People could walk 7 less meters over time. Whereas with the IV iron, they improved it by 18 meters. So a 25 meter delta there. We gave approximately, the average patient needs about 1,200 milligrams of iron to replete their stores. We gave over 100,000 milligrams last year. And then newest medication we've been using is GLP-1s. South Carolina has an obesity epidemic. Certainly, if you can't breathe because your heart is not circulating your blood, it's not going to be any easier to breathe with an extra 30, 40 pounds on you. So we have a robust weight loss clinic here to help some of these patients out. The insurance authorization is getting easier. It used to be only for type 2 diabetics. Now it's expanded to patients with sleep apnea. Medicaid is picking it up for weight loss for South Carolina. and so Zepbound is the same molecule as Mounjaro, which is tirzepatide. We're seeing patients on the high dose, the 15 milligrams, lose on average 21%. 25% of those patients lost over 50 pounds. So it is significant weight loss reduction. These are like bariatric surgery numbers. So we try to maximize the other medications we discussed to kind of help alleviate their shortness of breath, help people walk a little farther. But then we can add on, the GLP-1s, which will reduce their comorbidities such as sleep apnea or diabetes, and then get the weight off, which will help exercise tolerance and breathing. So that's it for the medication. So what do we add to augment those medications? We do a lot of remote monitoring. Part of that is, again, because of the geographical spread of our state. If someone's living 2 hours away, it is much easier to communicate over phone rather than asking them to drive into Columbia every 2 weeks, particularly having to go through Malfunction Junction. So we have multiple different devices here. It helps us fine tune our diuretics. Diuretics are a great resource, but too much diuretic, it leads you into a kidney injury. Too little diuretic leads you into the hospital. So it's always a fine line. Obviously, patients' diuretic use does not stay stable year round. It's around the holidays, maybe had some holiday ham. They're going to need a little extra Lasix. If it's South Carolina and they can work out in the garden, they're going to be sweating all day. They need a little less Lasix. So having remote monitoring aids us to keep people out of the hospital, to keep their kidneys healthy, and kind of give them good quality of life. It, again, helps with heart failure exacerbations. We also have multiple telehealth services, which we'll go into in a minute. These services are based elsewhere, but they will call and check up on patients. They can do medication teaching, and they have a system to escalate patients' needs to us if required. And again, all this is to reduce clinic visits. So type of remote monitoring devices that we use and are generally used nationally are Cordella or CardioMEMS. The picture on the top right corner, it kind of looks like two paper clips with a like a level in the middle of it, is a CardioMEMS device. This is a PA pressure monitor. So we insert this into the pulmonary artery. We do it through a vein. It takes about 15 minutes, and then it becomes part of the patient's pulmonary artery and stays with them for life. And this will transmit the pressure in the chest back to our remote monitoring team, and that correlates to how much fluid is in the body. And then on a not permanent basis, we have thoracic impedance devices, which we have two. One's called HFAMs. This is a sticker that goes on the patient's left chest, and it measures resistance in the chest, right? So electricity goes through water easier. So if their resistance is down, then we know there's more water in their chest, and we call them and say, hey, how you feeling? You got, is your weight going up? And another device that does it similar, some patients' ICDs will have a heart logic index, which also uses thoracic impedance to monitor the fluid in their chest. So again, these are used to fine tune the diuretics, keep people at home, which obviously gives better quality of life and some palliation from their disease burden. And these are some of the home companies that we use. We have two companies we partner with here. They can do home vitals monitoring, so checking on blood pressure, weights. Typically what we use, they'll do home health coaching. They'll escalate events to us if needed. Kind of an effort to, do a lot of the medication titrations and monitoring at home, rather than having to make people travel or getting to those people that can't travel as often because of distance or other comorbidities at home. And we'll do this stuff even for people who are on home hospice, because, a lot of times when we talk about hospice, everyone wants to stop everything. They've accepted the dying process, but the dying process is a lot more uncomfortable if you're drowning in fluid. So you can give people all the morphine in the world, but it's much easier to just give them 40 milligrams of Lasix to relieve some of that pain. So we still maintain relationships and the monitoring with patients on hospice at home. Home health services, again, are amazing to keep people at home. Crystal can talk a little bit more about those, but vital signs. We have to do frequent lab draws because of our medications. To be able to do that at home, not having people come in. A lot of our palliative home health service here will have nurse practitioners and physicians that will do either home visits or televisits with patients. Again, there's a lot of home health coaching, and a lot of our patients have wounds, particularly in their lower extremities, from chronic edema or weeping or poor circulation. A lot of people have concomitant, peripheral vascular disease or peripheral arterial disease, lymphedema. So wound care has been a big resource that we have at home and sometimes do in clinic as well. And then rehab services. So we partnered with a company called ROM Therapy, and that's the device to the right. It's basically a Peloton that gets mailed to their house. And you can see there's a little coach on there, and the guy's pretending like he's riding his mountain bike through the forest. But just another thing to kind of make life a little bit easier for patients rather than having to travel or arrange transportation. We can do this at home. For the patients that are more mobile, we get them into cardiac rehab or pulmonary rehab probably yearly. So for most insurance plans, we found that their rehab days, most people get 36 sessions. So let's say 3 sessions, 12 weeks. They renew annually on the 1st of January. So we really try to get people into that as much as possible, especially for the older adult. We all know after 65, nutrition is not the best. You start muscle wasting, protein becomes more important. So the more we can get people into those services, the healthier the rest of their body will be, and it'll also strengthen their heart. And then of course, post-hospitalization or for other needs, we'll use physical or occupational therapy. So devices, these devices we're going to talk about here, we're going to focus mainly on their quality of life benefit, although most of them will have potentially increase in ejection fraction, decrease in hospitalization, decrease in diuretic use. But we'll focus on the Kansas City questionnaires and the 6-minute walk times again. So the grade 1 and the first thing that we assess for is a device called cardiac resynchronization therapy. And this is a pacemaker that we put into the chest, and it lives in the subcu tissue. And then the leads go through your vein down into your heart. And that's that purple, teal, and light blue leads there. One lead in the atrium, which senses your heart's intrinsic beat, and then one lead in each ventricle. And we do this because patients with chronic heart failure, they either have scar or fibrosis from heart attacks or genetic reasons or infiltrative cardiomyopathies. And you get kind of that wide complex QRS that you see on the top part of the blue diagram. And that lets us know that for whatever reason, electricity is not arriving at that portion of the heart at the same time it should be. Your left and right ventricles should depolarize and contract at the exact same time. And when you see a wide complex right there, you know that one and then the other is going, and that what gives you the wider QRS. So we override pace the heart, and even though we're doing artificially, we're putting into a more natural pattern of beating, bringing that dysynchrony between the right and the left ventricles back together so that they can have more functional capacity. And we do see some improvement in ejection fraction, things like that. So again, the top part is a wide QRS. This is what your heart would look like prior to therapy. And on the bottom, we see a narrow QRS. So having a more natural heartbeat, and that's what we see on the EKG there. So the data for this, I'm sorry, this is blacked out a little bit, but I have it on my other laptop. And these are 2 different studies, both done in class 3, class 4 patients. With CRT at 6 months, we saw an increase in 6-minute walk times of 39 meters and 29 meters by 2 different studies. And we saw their Kansas City questionnaire scores improve by 11 points and 9 points. So going back to those medications we were talking about earlier, we saw 1.5 point improvements. We're talking 11 and 9 points. So this is a significant improvement in quality of life, and our first class 1 recommendation for devices after optimization of medications. The next device here is Barostim. So essentially, when you have chronic disease burden such as heart failure, your body gets locked into a sympathetic fight mode, which is great to run away from a bear, but it's not great to live in constantly. So this device lives in the fat in your chest, and its lead goes up to your carotid arch where you have baroreceptors. And baroreceptors' normal job is to account for the positional changes and mitigate them with changes in hemodynamics. For example, when you stand up too fast, your heart rate increases and your blood vessels tighten, so all the blood doesn't go to your feet. So this device sends signals to the brain, blocking out some of its natural impulses, therefore deregulating the sympathetic nervous system and upregulating the parasympathetic nervous system, our relaxation system, so your body can be in a more natural homeostasis, and that makes it easier for your heart to pump. And what we see in the data is people are walking much farther. So if you see at 6 months there was a delta. It was actually 65 meters. The placebo is white and therefore blanked out on the bottom there. But there was a delta of 65 meters from people who got worse without intervention, lost about 9 meters, and then people who had the intervention gained 56. So, and then at 12 months, we see that again with about a 47 meter delta. So we see a significant change early and then sustained at 1 year. Now there's 2-year data out that is mirroring this result. And then in the change in Kansas City questionnaire, improvement by 10 points, which was sustained out to 2 years. So again, a much larger number similar to that of CRT, nearly 10-fold that what we see with just medications. So for Barostem, we're one of the larger implanting centers in the country, or really the world. We've done about 125 devices between our 2 centers, and the results are outstanding. We've seen people who could, not make it through a workday come back running on a treadmill. So to put those numbers in perspective, it is a huge improvement in quality of life. I had another patient come back the other day and said he cleaned his fridge out. And I was like, well, so he goes, I haven't cleaned my fridge out in 6 years. I didn't have the energy to, nor the motivation. And you guys put this in, and now, I can't stop cleaning my house. And now he's back to work. So a significant improvement to alleviate some of the burden of heart failure. Now, this device does not fix heart failure. It's simply regulating the nervous system. So we have seen in some centers improvement in markers such as ejection fraction or hospitalizations, but the pivotal research for this type device was just quality of life improvement, and that's how we market it. Another device similar for quality of life improvement is called cardiac contractility modulation, or CCM is the other name for it. So this device is a pacemaker-like device. It has 2 leads that go down into the muscle between the right and left side of the heart, the interventricular septum. And this pacemaker senses after the 2 ventricles contract and delivers about 300 to 400 impulses, which then help release calcium and give a stronger contraction. So you'll see on the diagram there a normal QRS, just like we saw with the CRT, and then one with the device activated, which you'll see like us oscillating electrical activity right after the depolarizations of the ventricles. So again, this is a quality of life device, and what we see here in the data is significant improvement. So again, you see the MLWHFK, that's the Midwest Quality of Life Heart Failure Score, similar to the KCCQ. So we see the gray there is placebo. The light blue is CCM for the full range of reduced ejection fraction, so from 25 all the way to 45. But we saw the most significant improvement in the kind of dark gray color there in the 35 to 45% arm of the research trial. So people with ejection fraction 35 to 45%, and they had 15 points improvement in score. And you can see there the benchmark for clinical significance is 5 points, so 3 times fold over the benchmark for clinical significance. And then the 6-meter hall walk test, which we just discussed with the Barostem and the CRT, we saw a 57-meter improvement. And this is through, the study was 12 months, I believe. So sustained out to 1 year, similar results to the Barostem. Again, clinically meaningful improvement would have been 25 meters. And then we see this in Barostem as well, although it wasn't listed. Patients improving at least one NYHA class. So again, we talked about earlier, our job is to keep them class 2, class 3. So moving from a class 3 to class 2 is a significant improvement. Put that in perspective, class 2 is defined as, symptoms of heart failure with exertion, extreme exertion, such as if you were going to play a pickup basketball game and you couldn't do as well as you could, 6 months ago, versus class 3, which is I can't go to Walmart without getting into a buggy. So a significant improvement in exertional symptoms. And the last thing you see there, and we didn't talk about earlier, is peak VO2. So peak VO2 is a product of a cardiopulmonary stress test. This is what you see athletes in Gatorade commercials doing when they're wearing the mask and they're running on the treadmill. It measures directly the exercise tolerance of your heart. And we see an increase of 1.7, which is, basically double a placebo. So that is a significant improvement. And this was one of the first studies to actually track that as far as improving quality of life. So lastly, things that we can do to help heart failure, but we'll focus on the quality of life here, is oftentimes because the left ventricle runs into trouble, it affects the valve, which controls the flow of blood into the left ventricle, which is the mitral valve. So in a young, healthy person, we often do surgical valves. So that's the diagram on the left. You see a mechanical valve, or you see a artificial biologic valve, like a pig valve there. So that would be a full sternotomy, crack the chest, replace the valve. And by fixing that valve, you can stop regurgitant blood flow going from the left ventricle back into the left atrium, which then courses into the lungs. So you can imagine if you had a lung full of fluid, it's going to be very hard to breathe. You're going to be tired all the time. And eventually, as the disease worsens, it will back up to the right side of your heart, causing fulminant heart failure. So in young people, we intervene with surgical valves. The diagram on the right side of your screen is a newer technique called a TMVR, which is a transmitral valve repair. This is similar to a TAVR, but has only been out for about the last year or two. Still an emerging science, but you can see they ran a catheter up the superior or inferior vena cava and then punch across the atrial septum and then place the valve in the mitral position. And this is a surrogate to replacing surgical valve. There's no studies yet comparing them directly, but we're seeing promising results. It's been done about 3-4 centers so far. But the one we see most often here in the Midlands is mitral clip. And this is for more advanced patients, sicker patients that can't go through large surgery or have other things precluding them from getting a TMVR. And this is essentially a staple that we put in the valve, bringing the leaflets of the valve closer together to minimize regurgitant flow going from that left ventricle back into the lungs. So similar approach as the TMVR, just a smaller catheter, and obviously rather than leaving a valve there, it's just a clip. And what we see here for functionality and quality of life improvement is, again, we see most patients starting, the red there is class 4 symptoms, and you can see after 30 days, the percentage of patients with class 4 has dropped dramatically from 11.3 to 2.2, and then at 1 year down to 3.1. So majority of patients baseline to qualify for this device are class 3, and it drops dramatically from 67% to 17.7, and then maintains that at 1 year at 18.4. So it can have a dramatic improvement in functional class, and then also undiagnosed mitral regurgitation over time will cause fulminant heart failure. But again, in the short term, we see dramatic alleviation from burden. And again, this is reiterating kind of the improvement with MitraClip. So the blue line here is MitraClip plus medications. The red line was medications alone without intervention, and it stops there at 36 months because they couldn't ethically continue people in the study without giving an intervention that they know works. About 50% of the people in the placebo arm of the study, by the way, died at 1 year. So high mortality, and then obviously we saw the functionality improvement. And then the last blue line there is GDMT with MitraClip intervention at the 36-month line. And you can see how that graph was previously fairly sharply sloped and then levels out to mimic more of the blue line after the 36-month part. And just kind of go over our team. It does take a village to take care of heart failure. Obviously, we've gone pretty in depth for multiple treatment modalities so far, and these things are expensive. We live in a lower income part of the nation, and it takes a lot of people to implement, monitor, and track these things. So I just want to kind of go over a little bit of what our team looks like. We have 3 board certified heart failure physicians. We have 9 APPs. We have 2 clinical pharmacists, and our clinical pharmacists are excellent at getting us grant money, manufacturer's assistance, prior authorizations, buying insurance companies. We have an amazing social worker, Crystal, and dedicated remote monitoring team to do all those various devices we were talking about earlier to kind of help our patients on the peripheral of the state. And then on top of that, we have 18 other support roles in our clinic, really about 20. So it takes a village. And what I can say to you guys that are out there in North and South Carolina or where else is, if you identify these patients or see or have patients that aren't getting the access or the resource they need, make sure they get to a certified heart failure center, because other clinics just simply aren't built to handle the demand that this disease brings. And without this large staff, without our resources, the chances of success are smaller. And so make sure they're getting to the right area, and that's one of the biggest ways you guys can help. And then kind of the takeaways is, obviously there's a lot of treatment modalities we talked about. No one way of doing things is right for any patients. We're always trying to individualize a treatment plan. We listen to our patients. We listen to things that they might not want. Some of our patients don't want an ICD because they don't want to live in fear of being shocked by it. But that doesn't mean I'm not going to give them another implantable device that improves their quality of life, right? So we try to tailor the plan, kind of educate the patient and answer questions and just be patient. That kind of goes into with treating the whole patient. So we talked about heart failure medications and weight loss medications, for example. And some things we didn't talk about is getting people like sleep studies and getting to the dietitian. And we do all that stuff as well. So we're trying to, treat the whole patient and minimize some of the other comorbidities they might have that could be exacerbating their heart failure. Again, refer to a heart failure specialty clinic early. A lot of times people ask me, well, when should we refer to heart failure? When someone's diagnosed with heart failure. As soon as they're diagnosed with heart failure, the clock's ticking. They're going to be beating the statistics to be alive at 5 years. You wouldn't have someone diagnosed with lung cancer be like, oh, when should I go see an oncologist, right? They're getting in the next week and they're starting on chemotherapy. These medications and devices are our chemotherapy. So you have to get people referred in early so that they can get the treatment they need. And interdisciplinary team approach. We talked a lot about our center, but we work very closely with general cardiology, with vascular surgeons, cardiothoracic surgeons, even our social work team, palliative care team, hospital administration, psychiatrists, psychologists. So even outside of our little village here, there's a whole city taking care of patients. Be aggressive. Again, we got to refer early, get them on these therapies early, because even if we prolong their life with medications, we could have given them a device, that made the time they have even more enjoyable, right? What's the point of keeping someone alive if they don't feel alive? I have people, ask me all the time, like, well, I'll ask them, what do they want to do? And they go, I want to be around to see my grandchild's graduation. I'm like, well, great, but don't you want to walk them down the aisle too? So, we want to keep people's functionality as high as we keep their mortality low. And that kind of goes into the last point is, support doesn't end at the clinic door. So I would say we get paid for probably a fifth of what we actually do here. I mean, we do the clinic visits, but so much is calling patients at home, doing the remote monitoring, doing the education piece, keeping people out of the hospital. We do infusions in the clinic, blood, diuretics, iron. So it's really, we're kind of on call. It's almost concierge medicine. We joke sometimes, but that's what we have to do to keep people out of the hospital, and it works. I mean, our readmission rates are some of the lowest in the country. Our length of stay data is some of the lowest in the country. Our GDMT data, our medications, are some of the highest utilization in the country. And we already talked about how we implant some of these devices at the highest rates in the country. So it all kind of fits together. And that brings us to our last point. And I love this quote for Shawshanks. I guess if it comes down to a simple choice, really get busy living or get busy dying. And kind of for heart failure, that's kind of the crux of it. And you have to be aggressive, and it's, you got to keep putting 2 feet forward. You're going to take a step backwards. And with that, that's all I have. I'm going to turn it up. Oops,
Okay.
I broke it again.
That's okay.
I'm going to turn it on over to Crystal. Talk a little bit about what she does with social work.
Oh, good. Thank you, sir. All right.
While Crystal is getting settled, hey, put your questions in the chat. I've got so many questions on my piece of paper here. Yeah, that first part was amazing. So, Crystal, we're ready for you.
Awesome. Give me 1 second. Oh, wait. You all are still seeing the screen, correct?
Yes, we are.
Yes,
We're still
we
seeing
are.
the screen. The one that's up is, there you go, my why.
Okay, I got it now. All right, so I'm going to jump in with morbidity and mortality, and just starting with my why. Good afternoon, everyone. So I came into this position and back into healthcare in December of 2021. The picture on the screen that you're looking at, this is an image of my dad's heart in 2019, where he had gone in. They were trying to insert stents, but his heart was not receiving them, and ultimately he got sent home without the therapy. But what was so interesting at that time was that we learned that his heart had actually grown a collateral blood vessel. So it was working to support itself, even though he could not receive medical intervention. So I just wanted to share this information in terms of my family connection, in terms of life experience related to heart failure. My dad had 5 heart attacks over a 26-year period, and his last one he had in 2021. So just wanted to share that. All right, so physical inactivity in terms of morbidity. If you look at this map, you can see that we are deep in the stroke belt. We are in the heart attack belt here in South Carolina. And if you look at, what the heart is, a muscle, and then the impacts that you have across health span in terms of your heart being able to function well, and the comorbidities, other organ failure that may come along with it, or dysfunction. It's really critical that we pay attention to heart health, heart failure, and do what we can to support our patients as best possible. And prevention, I think, is an applicable word to use here too. Prevention, as much as we can, and that includes use of guideline directed medical therapies as well, to offset or delay progression to the extent that we can is helpful. All right, so now looking at heart failure prevalence. So Michael already shared that there are approximately 6.7 million people over age 20 who have heart failure. And on this screen, I just want you to observe the projected number of millions of people who will increasingly have heart failure. So approximately 1 in 4 people will develop heart failure over the course of their lifetime. So think about people that you are related to. If you're from a family with one parent and 6 siblings, or if you have a grandparent, your aunts, uncles, cousins, siblings, etc., somebody you know is going to be diagnosed with heart failure. And it's going to be more of a problem. Prevalence will increase in the future. And if you think about demographics as well for the South, including South Carolina, and if you look at health disparities, the data is showing that minorities or disparate populations are actually having significantly more increases with these issues. I will say one thing that is really interesting about South Carolina in this vein. When you look at patients who have LVADs, nationwide, most LVAD patients are not minorities. But when you look at South Carolina, given the disparate or disparities in terms of minorities with heart disease, heart failure, we're actually implanting more minorities with LVAD devices in South Carolina than than other populations, which is really interesting. Okay, so heart disease deaths. According to the National Center for Health Statistics, these are rankings from 1921 to 1923, with the, excuse me, from 2021 to 2023. We're in a whole nother century now. And the 2023 data is actually, this is provisional data. So CDC is still working through it. But, you know, back in 2021, at the heart of the COVID pandemic, COVID was not the #1 cause of death in this nation. It remained heart disease, followed by cancer. And you see in 2022, when we had a bit of a better handle on the COVID pandemic, we came back to heart disease, cancer, and unintentional injuries. Heart disease deaths continue to climb. I want to say between 2022 and 2023, there was a significant jump in deaths, somewhere between, well, let me not quote numbers, but it was not quite 100,000, but it wasn't too far off. I think somewhere between 60 to 80,000 increase in number of deaths total, that's a lot of families impacted by heart failure or heart disease. So heart failure specific deaths, heart failure accounted for 45% of cardiovascular deaths in the US in 2021. It was a contributing cause in approximately 425,000 deaths in the US, and that's out of 700,000 plus total cardiovascular or heart disease related deaths in general. So it is a significant problem. So I wanted to use that data just as a setup or a framing of the conversation about advanced directives. The last thing I'll offer in terms of data is that, most people think that they've got more time, or maybe they're not thinking about it. But when you look at the data in terms of where many people are dying for heart-related causes, almost 3 in 4 will not die in a hospital or nursing home. Most people are having their significant events in a home setting. And so it is very important that advanced directives become a more regular part of family conversation, patient conversations, regardless of their age. Grounding quotation. It says, I have an advanced directive, not because I have a serious illness, but because I have a family. And that quote is by Dr. Ira Byock. Some people's families are blood, some people's families are not blood. But if you have a family, people who love you, you love, it's really important to set advanced directives. So advanced directives, we're focusing on healthcare related advanced directives today. But, advanced directives also are things like your last will and testament, durable powers of attorney as well, and general power of attorney. The oldest known advance directive, there was an Egyptian gentleman who left all of his property to his wife named Tita. Here in the US, it was 1954 when the state of Virginia uh, created its first durable power of attorney. In terms of looking at a health-related advance directive, it would be 1967 before we entered that in this country. It was 1991 before there was the Patient Self-Determination Act that made sure people are informed about their rights to participate in healthcare decisions. And if you look at a website of any organization that receives federal funding, they have advanced directives on on their um, their websites. So people have to be informed about their rights to make decisions. And by 1997, there was prevalence of every single state in this nation having a healthcare power of attorney statute on their books. So we've made a lot of progress in a little time. So looking at the actual advanced directives, I have posted here, pardon the pun, I've posted here just several commonly used advanced directives. I did not include post, but it is an advanced directive. Living will is typically used for people at end of life, older persons, people that can't be cured, they're in a permanently vegetative state. Healthcare power of attorney, this was what we most frequently help patients complete in our clinic. Um, you don't have to have a medical provider sign or witness a healthcare power of attorney. Actually, they can. So healthcare power of attorney, that's something that I typically am able to help patients do here in the clinic. Organ and tissue donation, that can be included on the healthcare power of attorney. If you have a state issued ID, such as a driver's license, you know that you have given them your yay or nay um, in that regard. There's also the do not resuscitate orders, which are placed on a patient's chart while they're inpatient, as well as the do not intubate order may also be placed on a patient's chart while they are inpatient. And I'm going to backtrack to the do not resuscitate order, or the DNR. A lot of people are not aware that there is a community level or an EMS level do not resuscitate order. It's available through South Carolina Department of Public Health, formerly DHEC. And if you use the sources link listed here on this slide, you'll be able to access that, actually help the patient complete that within the last couple months in the clinic, who wanted to make sure that she had covered all of her bases. She had the living will, she had the healthcare power of attorney, but she wanted to make sure that if 911 was called to her home because she was unresponsive, she wanted to make sure that they did not administer any care. This woman's in her 90s and felt that she'd had a nice quality life, and she was prepared to transition naturally whenever that time came, and wanted to remove all barriers to that. The last advanced directive listed here is 5 wishes. It is written in very plain language, everyday English, and it covers all manner of wishes, including personal, spiritual, medical, and legal wishes. So it's all encompassing. So let's talk about benefits and barriers. And I'm moving fast because we need to leave time for questions. So please get ready to ask questions. So quickly talking about benefits. Advanced directives empower patients to plan ahead, the keyword being advance and directive. It protects a person's right to self-determination. You know, your children can't force you to adopt an advanced directive position that you don't wish to take. So it's protection. It also reduces intra and inter-family conflict near or after death. So in that regard, it may protect peace within the family. So it protects the family, it protects the patient, um, and lets people focus on what's really important in life, which is their human connections and their relationships with each other. And that's what we focus on in our conversations with patients here. It also helps strengthens our systems of care, and it helps us to keep patients at the center of what we are doing. Okay, so let's continue this discussion rather with key barriers. So starting with patient and caregiver factors, this is really a list of myths and assumptions that patients make related to advanced directives, and it's reasons that they would not complete them. And it's important that we be aware of that as professionals or as community members that people may trust and have these conversations with, so that we can debunk their myths as we encounter them, and just empower people to make decisions that may be fruitful for themselves and supportive of their family connection. The first one here is that my loved ones, they already know um, what I want to happen. Research shows this is not true. More frequently, loved ones guessed wrong what their family members' wishes were, which could mean a person who did not want to receive life-sustaining treatment could be left on a ventilator for some period of time in a vegetative state, for example. Or, a frail person may receive CPR and they end up with collapsed lungs or broken rib cage because they didn't want that heroic care, but their family member, they thought that's what mama, that's what my uncle would want, and that's what happens. And so they're alive, but they're suffering, and they wanted to die a peaceful, natural death. Number two, it only matters if it is in writing. It's really important to have conversations, even if a person does not have a legal document such as the healthcare power of attorney or the living will. If they've at least had the conversations with their loved ones, it is still helping that family to make informed decisions about what that patient's wishes were, which means the medical professionals can provide care based on that patient's interest. And so it goes back to patient-centered care in this document, or not documents, even conversations, planning, advanced care planning, being really, really critical. Number three, I need a lawyer's help. If you're talking about completing these documents, you can get a lawyer's help. You don't have to get a lawyer's help, but it's possible. Here at our hospital, Michael talked about our team. The medical providers, they can do the living wills themselves. Healthcare power of attorney, I can help patients complete those. Other team members can serve as witnesses. One of our nurse practitioners and myself, we're both notaries, so we can notarize advanced directives for patients. Healthcare advanced directives only, though we stay within our scope of practice. And we do that at no cost for patients. So it's an added bonus for patients for us to be able to say to them during our conversations with them, we can help you do this, and it won't cost you a dime. And we will add it to your medical record for you. Number four, I'm not old or sick enough to need one. We serve patients, the youngest I've seen is 18, 19 years old, on up through patients 100 years old. So we serve a wide range of patients, and there's no such thing as being too young to have an advanced directive. Five, once I plan, I can't make changes to it. That's a fallacy. These documents can be changed at any point in time. So whenever I am helping patients complete the healthcare power of attorney, for example, we go through what the document is, and I reiterate the fact that you can make changes at any times. And also reiterate the fact that this document is in effect during periods of time when you are incapacitated, either physically or mentally. So if, as long as you're able to speak for yourself, we're not going to call your family member to make any decision on your behalf. You will be making those decisions independently until such a time comes when you can't. And then number 6 here, if I plan for this, something bad's going to happen to me. Some patients may be more superstitious than others, or may believe that it's an omen. If I start talking about death and making decisions about when I die, it's going to hasten it. It'll speed that process up. And so that's also a conversation to have with patients about the pros or the benefits of planning, and the opposite of what may happen um, in the absence of it, while also respecting the fact that they have a right to their thought process and perception as well. So we let things remain in the patient's hands. And just here in this window here, other factors, changes in mental status. Some of our patients have declining cognition or cognitive status, which may impact decision-making ability. So low health literacy, this is South Carolina. So we have a number of patients, they haven't even finished high school. And so they have low literacy, and for some people that may translate also into low health literacy, but even patients with higher level of education in general still not be quite aware of their health condition, the progression of it, and so they may not understand why it's important to go ahead and complete the advanced directive. Um, Also, there could be systemic trauma. There are some groups in our country that they've they have been on the receiving end of just population level trauma or very specific systemic traumas that lead to low trust in medical systems, et cetera, or government systems. And with these being legal documents of a government, some patients, they don't trust it. And so I also make a point of letting patients know, like in terms of witnesses, we have to be very specific in terms of who actually witnesses these documents just to legally protect you. So I'm going to transition now, and we're going to talk about physician barriers. Essentially here, physicians don't always have time to have these conversations in depth, but we do make a point of having conversations with our patients about advanced directives at multiple points in their dealings with us. And I'll get to that briefly in a minute. And, for primary care doctors, as patients get older and sicker, they are spending less time with their general providers, and they're spending more time with specialists. And if they're also having multiple rehospitalizations, even for a specialty clinic like us, we're seeing them less. And so you have less interaction with that patient. So the hope would be that when they are also inpatient, they're also getting that support, which we also provide inpatient support for advanced directive completion through our chaplains that work with palliative care at Prisma Health. So ways to include advanced directive completion into your practice. First and foremost, it's important to build rapport with patients and their caregivers. Sometimes patients are really receptive, but there are other times when they just are not. And it is really important to be able to have emotional intelligence as a medical or healthcare professional, and be able to build rapport with both patient and caregiver. Below that, I have listed iterative conversations. So, we have conversation about advanced directives when patients go to registration. So the registration desk personnel at Prisma Health, they're asking patients, do you have an advanced directive? If they have one, They will note it if they have the copy with them, which we encourage patients to bring that copy with you to your appointment. The registration can upload it to their chart. But here within the clinic, the medical providers can have that conversations with patients. And also they can bring me in to have that conversation with patients, whether it's they've had the conversation, the patient is now ready to complete the healthcare power of attorney, or if the situation is that our clinic is booming and busy. We're a busy clinic. We run multiple schedules every day. It could be that they have a patient come sit with me in my office after the medical visit is complete, and I can finalize that, or I go into the patient room and help them with it. Sometimes we give them a copy of the advance directive and they can take it home and just take it and review it. We understand that you're not ready to do it right now, but at your next visit, just come back in and we can do it then. And so that helps. I've already alluded to staffing, and Michael has too. We are not on an island. We depend on a lot of people to support patients here. And that is here in our clinic registration, but it's also team members upstairs. There are inpatient social work and nurse case managers that we collaborate with, as well as medical providers. You know, we remain open, like Michael said. So you might get a phone call from someone. It might be Friday at 5:45 p.m. and a phone call might come through and you answer it because you want to make sure patients have what they need. So that's just what we do. We also have resource availability. There's a resource wall that we've created, and copies of the healthcare power of attorney, they're always there. It's even listed in Spanish. And so a team member like Michael does an excellent job of sharing documents with patients that will help them increase their access to care, and their position and empowerment in their care. Standardized talks I've already talked about. It's not our driving force for helping patients with advanced directives. We just want patients to have increased health literacy and increased agency. But we also have advanced directives as a metric. And so we are regularly able to look at how well we are doing in this area, and we're trying to improve it as well. Giving patients agency to make decisions for themselves, super important. Again, we don't push it on them, but it's an option. And we meet patients where they are. We maintain a position of empathy, and we educate patients on things that they are not clear about. Frequently, when talking about advanced directives, patients will say, I got that. I know who I'm leaving everything to. And so we have a gentle conversation about medical advanced directives. And, you know, I applaud them for taking care of their non-medical advanced directives. I don't know that we have time to go through all of these scenarios here, but I will just highlight that it's really important that patients consider their personal situations, not just look at age for doing advanced directives. For example, there's one patient that, more than one patient actually, that have come in, they've been separated from their spouse, and they didn't have an advance directive. So we were able to help them take advantage of an opportunity and appoint another family member other than that spouse that they're no longer with to be their healthcare agent. You know, it's important to be able to hold rapport with patients and their family members, and remembering who the patient is. You know, on occasion, there will be a situation where I'm called in to see a family during a clinic visit. The children don't want their parents to be a DNR or to say, I don't want to receive life-sustaining treatment. But the patient may realize that, you know, I've lived a full life, and my doctors are saying there's not much else they can do at this point in time, and they're ready to not have any heroic measures offered. And so I usually I have to get Kleenex for those conversations, frankly. But we have the conversation and the children are able to accept it, and that patient is able to move forward, and they create the advance directive in a manner that is suitable to their wishes, not the families. Um, and a lot of the support that I offer for advanced directives, a lot of it is related to it, the LVAD workups. Michael, I think, alluded to LVAD also in his presentation. Those patients who are typically they're inpatient preparing for this major surgery that is just one heart therapy beneath the heart transplant, and often used as a bridge to a heart transplant for patients that are ineligible for it immediately. And it is just, it's critical work. We even work with hospital security in terms of getting advanced directives done. So when we say that we work together, we really work together here at Prisma Health to support our patients with the medical therapies, as well as access to no cost advanced directive support. And I'm going to show you our contact information. And Marisette, I'm going to turn it back over to you.
Wow. Oh man, this is amazing. And if you'll stop share so we could see people on the squares. Thank you, Crystal and Michael, for an amazing overview from the clinical perspective to what happens when you care for patients and families. I can tell the love and the passion that you guys have for the work that you do just in how you've conveyed that to us today. So we are absolutely honored that you guys would take the time to do that for us today. So I know it's about 1:19 and we're wrapping up at 1:30, but just a couple of questions for you. One has to do with when you think about this, the gravity of heart failure in South Carolina. I'm curious as to what kind of outreach you know that's happening in the state to educate individuals around the gravity of this and what can be done. So often we fear cancer more than we fear heart failure, right? It's sort of this mindset, oh, cancer, I'm going to die right away. Whereas when we see the statistics that heart disease is number one, we've got to change the narrative. And so I wonder what is being done in terms of community connection and outreach. Like I'm going to a church tomorrow to talk about this month is Healthcare Decisions Month. I want to put that into the presentation, right? So tell me what you know about the community outreach.
Um, what I know about community outreach is a little limited. I do know that there is an organization called Mended Hearts that is local, and they offer support for patients. Actually, one of their members does bedside visits to our prospective LVAD patients at bedside. He will take them a tote bag with some information in it.
Mm-hmm.
That is what I know of what happens locally. And there
Mm-hmm.
are Mended Heart chapters across the country. I'm not sure if there are Mended Heart chapters in other parts of the state.
Mm-hmm.
But I will say that in terms of if you think about healthcare being integrated into communities, Prisma Health, and I'm sure other hospital systems like MUSC are doing the same as well. We actually are operating cardiology clinics in multiple counties
Mm-hmm.
around the state.
Mm-hmm.
And so we're increasing our availability for patients to get care that way.
Okay.
Michael and well, actually, all of our not, I shouldn't say all of us, most of our medical providers here in the Advanced Heart Health Center, they rotate, they provide coverage in those cardiology offices. We have one medical provider that I think once a month she goes to an OB/GYN practice and provides support to pregnant women or expectant mothers who are facing or dealing with heart failure. And so those are ways that we as an organization are interfacing with the community. And for patients who need greater level of care, we're able to refer them here into our clinic in Columbia. But we're serving patients across the state.
Mhm. That's amazing. Thank you for that. I think it's an opportunity for us to look at, patients that or community members that aren't sick yet but have loved ones. What we can do proactively so we can. I love the focus on enhancing the quality of life and the patient stories. Those are so key. I think the other question I had is related to oftentimes when people are referred to hospice, there is a little bit of concern about the cost for certain medications at home. But it sounded like from the things that you guys shared that there's not a lot of sort of IV things happening at home. They're implanted devices that happen before they get to hospice. Could you speak a little bit about that? I hear that often. Well, hospice says they won't. I know there's some concerns about medication payment, who's going to pay for the meds, and that there's a concern there. But it sounds like there's lots of work being done to sort of look at what are discounted meds that can, the purchase for meds and those kinds of things. Could you give us some information about that and why sometimes there's a little bit of a pushback from hospices and caring for these patients, primarily because they're responsible for the cost of meds and treatments?
Right. So my understanding is that under hospice care, hospice isn't, a, its purpose isn't to provide curative care for a patient, but it's to provide comfort care.
Mhm.
And so, for example, that may be the reason that there may be a difficulty in getting certain medications provided under hospice because some of those the medications like the guideline directed medical therapies, those are meant to help sustain life,
Mhm.
and prevent or reduce the progression of heart failure. So if a person is on hospice, um, my thinking would be that they would not be receiving
Mhm.
care that would sustain life.
Mhm.
If they had an infection, however, they'd receive medication, antibiotic, et cetera, and pain medication to
Absolutely.
mitigate that
Mhm.
uh, process. But I don't know that they would be able to receive any curative care or life-sustaining care on the hospice.
Yeah, and I think the quality of life piece is the piece I think that is challenging because of course when you're relieving symptom burden, but the prognosis may still only be 6 months, but you're relieving symptom burden so those 6 months are as good as the patient can do and can accomplish some of the goals that they have. So that's where I think it gets a little bit tricky in terms. There are some hospices who are taking on those patients because when they look at the prognosis and the fact that the quality of life is more the reason that they may be on medications, they're willing because they have a large enough patient base, they could take a hit financially on a patient's meds, whereas a smaller program may not be able to do that. It may be cost prohibitive for them. But I love hearing that you guys are working in a partnership with some hospices to do this so that, as you're titrating, on diuretics or doing certain things to make the patient more comfortable, even though it may not extend their prognosis for very long, but the time they have is more quality in terms of relieving the symptom burden. So that was very, very helpful to hear. So appreciate you guys being with us today. And certainly, I want to encourage you guys. We do have, thank you, Lavanya, for putting the Mended Hearts website up in the chat. You will see that I also put the evaluation. So if you guys would take a moment, you'll see the red cap evaluation in the chat. We would encourage each of you to do an evaluation. This was truly a wonderful presentation. I saw all you probably didn't see it, Crystal, but tell Michael there are lots of love given to you guys in the chat about people appreciating this presentation as you guys have kicked us off in high gear for the next 3 days. I want to remind everyone, of course, that we'll be back together again tomorrow at 12 o'clock. We will hear about a national palliative care heart failure pilot program that is being done by the American Heart Association. So Leah Tessatori is going to share with us about that pilot program and some of the outcomes with that particular project. And then we will round out the week on Thursday at 12 with Karen Nova talking with us about the outpatient palliative care model program that they have going on. So once again, thanks to everyone. There will be a copy of the presentation and also the recording. So share it widely with everyone. This is probably a great educational tool for folks as well. Crystal, I see your hand up. You had a question?
Yeah, just one other thing to share. In this world, very little is final except for death. And Marisette, you just reminded me that, sometimes patients, they go on hospice and decide it's not what they want.
That's true.
And so they'll come off of it. We have a patient recently discharged from the hospital. He has gone on hospice 2 to 3 times. And so
he's defied death.
yes, so death is the only thing that's final.
That's right.
Yeah, and these advanced directives can change, and sometimes patients do need to change them. So death
Yeah.
is the only thing that's final.
Absolutely. And I really encourage people when they're not ready. I do some work with some small programs and they still want physical therapy. They still want this, they still want that. And I say, hey, palliative care is a great option for those families until they're at the point where they're no longer desiring to do certain things that we consider sort of curative. Now, I think physical therapy can have two. You can have rehab and you can also have quality of life physical therapy. That's my mindset. There's a continuum. And so, but we want to meet people where they are and not force them into treatments and options that they truly don't want. And so that is really what we want to do. So this month, guys, Governor's Proclamation, Governor McMaster, it's Healthcare Decisions Month. We actually have that proclamation. You'd like a copy of it and you want to put it out there. We also have a way that you can promote this as well. I did send this out to one of the TV stations. I'm going to do one every day to see if anybody picks it up. But we want to encourage people to have conversations, as you said, anybody 18 years and older, and not wait till there's a medical emergency to try to put plans in place, but to have these conversations early. I find, Crystal, more churches are open to having us come in and talk about these issues. And so I want to encourage people, let us know if we can help you with that. And once again, fantastic job today. We're going to let you guys go. It's 1:30 and we look forward to seeing you tomorrow. Thanks again. Bye-bye.